Good morning, I'm Dr. Renne. I'm Assistant Professor of Pathology in Milan, and I will tell you about this case of in the Uropathology and soft tissue and bone pathology slide seminar. So our case, it's a case of a 66 years old male, and during the workup for a benign prostatic hyperplasia, 3 centimeters nodule was found in left pelvis. A year later, the nodule grew up to 4 centimeters. A CT scan and the magnetic resonance, that it's the correct exam for this anatomic site, was performed. As we can see at the magnetic resonance, we see that the left spermatic cord is enlarged and with the tissue, with a tissue with the same density of the fat that you can appreciate here. Moving toward the pelvis, we see that the fatty mass enlarges and occupies the pelvis, pushes toward the bladder, and here we see the nodule. So probably you might already have a clinical or radiological diagnosis in your head, but as you might imagine, we perform a core needle biopsy. We received a 1.2 centimeters fragment, and now I will show you the virtual slides. Okay, so here you can see a single core, as anticipated from the gross description. And as you might appreciate, to lower power, we have a very eosinophilic proliferation, meaning we have a lot of stroma, and no fat is evident at low power examination. You should always keep in mind that if you can review yourself the imaging, it will be a good proxy for the gross examination, especially on small biopsy. So, as you might appreciate, at higher power, we have scattered pleomorphic cells, spindle and spindle cells intermixed with with the inflammatory infiltrate. So this should prompt the taking in the back of your mind the fact that we had a huge fatty proliferation in the pelvis, that it's a typical site for a dedifferentiated liposarcoma. This should prompt in your mind the diagnosis of a dedifferentiated liposarcoma. In fact, so basically, as you can see, we cannot appreciate mitotic activity. We have a lot of inflammatory infiltrate, some pleomorphism, and scattered pleomorphic cells. So basically, this is the morphology of this specimen. Here we have some collagenization that resemble somehow bone formation, but we will see later, and a lot of plasma cells here. So the first thing you should do is to somehow rule in the differentiated liposarcoma. And the fastest way to do that is via immunohistochemistry, doing the MD-M2. Okay, so at low power, you can appreciate that we have our core biopsy here and also a positive control. Why? Because MD-M2, it can be a pain in the neck, as we scientifically say, so we need a positive control because we don't have, at least when we are not facing with the liposarcoma, an internal control. So we are not sure when it comes. So our positive control is in fact positive, and our biopsy do show nuclear positivity, that it's the right positivity for MD-M2. Okay, I'm trying to substantiate with the pictures what I said. So here we go. Okay, next, what we usually do on a bioptic specimen, once we are sure that we are dealing with the liposarcoma, we look for myogenic differentiation. And this is why myogenic differentiation is related to prognosis. And we define myogenic differentiation as the presence of actin or desmin in more than 10% of cells. And if we have desmin positivity, we also look for myogenin. Sometimes on biopsy, we do them up front for turnaround time reasons. So in this specimen here, we see that the spindle cell component do show an actin positivity. And looking at desmin, we do not appreciate diffuse positivity for desmin. Okay, so in this case, we expect to have myogenin negative, as in fact it is, and you can check it on the material on the website. Okay, so basically this is how we wrote the diagnosis. We saw a spindle cell sarcoma grade 2. We give each element of the grading and describe what we saw. We also perform, as you have seen, a few immunohistochemical stains, in particular actin and desmin, and myogenin. We will see later how these will impact on patient prognosis, and also we report the molecular status. Moreover, the patient underwent a CT scan, and then he underwent surgery. The surgical specimen was of the soft tissue of the pelvis with the spermatic cord and the testis. So we described the specimen, and within this specimen, we found the nodule that we saw on magnetic resonance images. And here are the slides. And here you can see the surgical specimen. So basically, piece taken at the interface between the dedifferentiated component and the well-differentiated component. Let's look at the well-differentiated component first. As you might see, at low power examination, we have the so-called dysmetria of adipocytes. So there is a change in shape and size of the adipocytic component. We have the fibrous septa filled up with spindle cells, and we do find the so-called lipoblasts, i.e. fat cells with the nucleus indented by the fat lobule itself. And in this case here, we have a sharp transition that was also heralded by the magnetic resonance finding, a sharp transition between the well-differentiated and the dedifferentiated component. Keep in mind that this might not be always the case, and they might be intermingled. And if we take a look to higher power of this, too much. So we take a look at a bit lower power of this component here. We see that basically mimics what we saw on the biopsy. We also can appreciate that there is much more inflammatory infiltrate, and we have the formation of some structure resembling the meningothelial nodules that we might find on the book while studying the liposarcoma. Basically, you move and look for more spindly component, and what the job of the pathologist here is to look for the highest, the area with the highest mitotic activity. That in this case it's very hard to find because mitotic activity is really low. So there is kind of overlapping between the so-called low-grade dedifferentiated component and the old cellular, the so-called cellular variant of the well-dedifferentiated liposarcoma. But these are probably stuff that represent a continuum, so it's fine to do like that. So in the slides, you will also find the specimen from the spermatic cord, and there in the fat you will see scattered cells of liposarcoma, and I cannot show you them for time reasons, and we shall move on to the discussion of the case. Okay, moving quickly through the to other morphological aspects, you see that here we have a lot of inflammation with scattered pleomorphic cells, and of course the spindle cell component. somewhere there are some collagenization, so we can see we can imagine this as a attempt to make bone metaplasia. Somewhere else there are area less beautiful to picture because they are calcified, but with full-blown bone metaplasia. And here you can see at low power the testis. This is completely atrophic. As you can appreciate here, we have certolization of tubules and hyperplasia of Leydig cells. Okay, basically, this is the final diagnosis, and you see that we describe the neoplasia again, so the differentiated liposarcoma, and we report the percentage of the component, even if this has not a prognostic impact. Moreover, we say which organs are infiltrated, and in this case are the pelvic soft tissue, the spermatic cord, and two lymph nodes are embedded, and we describe other features and the surgical margins of the viscera removed. I will add something about this in the discussion. Okay, at 4 months, this patient has no evidence of disease. So we are talking about liposarcoma. So liposarcoma, it's a pretty strange neoplasm in this paper that probably give the idea that liposarcoma is a tumor of lipoblasts. You can read how hard to pour this out, describe this kind of entity. So basically, what is a lipoblast? A lipoblast is a neoplastic cells showing a depositic differentiation where the fat component indent the nucleus. So this is a case with the gorgeous lipoblasts shown, but has a prominent soft tissue pathology says you should not be a lipoblasts hunter. And why? Because at least in the dedifferentiated liposarcoma, we know from a long time that there is a well-known a clear pathogenetic mechanism, that is the amplification of MDM2. And this amplification of the DM2 gene, it's caused by a chromosome amplification in the form of ring chromosome or giant markers. And this also helps to differentiate the different form of liposarcoma. And in fact, if we buy this simple molecular classification of sarcoma, in which we have activating mutation, inactivating mutation, complex genomic profile, specific translocation, and gene amplification, liposarcoma splits in several entities, and we have the differentiated, well-differentiated liposarcoma with gene amplification, the myxoid liposarcoma with CHOP translocation, and the pleomorphic liposarcoma with complex genomic profile. So we have a nice tool that allow to make the diagnosis, and this tool is the MDM2 amplification with the FISH fluorescent in situ hybridization exam. And this may also done with immunohistochemistry, but I personally have a very low threshold to FISH cases if even if immunohistochemistry is negative, and I have a high suspicion that this might be liposarcoma. And here you see what are the prognosticators. So basically, we do the grading of these sarcomas. So several papers, one of our group and from also other show this. So the grading is an relevant prognostic factor. And moreover, also the myogenic differentiation defined as at least positivity for actin or desmin or caldesmon or calponin. called simple myogenic or rhabdomyoblastic, i.e. Myogenin positivity, also have relevant prognostic information. Moreover, as you have seen in the report, I listed the organ involved, and I try to specify the kind of involvement. So if we have the tumor that is adjacent the organ, if the tumor is adherent, as in this case with the kidney, or actually infiltrates the viscera. Regarding the margins, I think we are not yet there, because there are very different surgical approach. So probably this will be a topic when the surgery for this kind of diseases it's more unique. So what are the differential diagnoses? Well, as you might know, soft tissue sarcoma, it's a very specialized field, and one should really practice it a lot for doing the diagnosis. But few differential diagnoses can be proposed when a spindle cell component of the liposarcoma is biopsied. For example, one could be the desmoid type fibromatosis. We have this case here, not published, also from spermatic cord, where the morphology it's the one of the desmoid type fibromatosis, and in fact this case has been diagnosed in several places as desmoid type fibromatosis, but these cases had MDM2 amplification and several recurrences, and more in keeping with also on the contralateral side, few years later, the first diagnosis we made, more in keeping with the differentiated liposarcoma. Other possible diagnoses are soft tissue, solitary fibrous tumor. As you might know, if you practice soft tissue pathology, they can be fat forming, and in particular, they can form lipoblast. But lobules of soft tissue are in fact lobules and not big big fatty areas of the neoplasm. And another thing that is further complicates the picture is that the differentiated liposarcoma also shows STAT6 amplification, and therefore STAT6 positivity by immunohistochemistry. And this is because STAT6 is a close neighbor to MDM2 that is a few kilobases later on the same chromosome. So when you have the ring chromosome, STAT6 can also be amplified. Another possible differential diagnosis for liposarcoma is the malignant peripheral nerve sheath tumor. Here we are really in trouble, because both these two entities have overlapping features morphologically and immunohistochemically, and molecular overlapping feature. And this leaves us just with basically all other information that are mostly the clinical stuff and the gross stuff or other morphological features. For example, the differentiated liposarcoma might have retained a well-differentiated component, whereas, as in this case here, diagnosis by these Japanese colleagues as MPNST, the patient was in fact an NF1 mutated patient, even if she had this neoplasm that had a cluster amplified MDM2 amplification. And in the end, also we have the so-called undifferentiated. So as you might know, the differentiated liposarcoma might not show the well-differentiated component, and it's important to identify these neoplasms that have just MDM2 amplification, because they behave just like the differentiated sarcomas. Okay, so what are the golden rules in the diagnosis? As many soft tissue sarcoma pathologists, we rely on multidisciplinary multidisciplinarity. So all the clinical information and radiological information should be gathered at the moment of the diagnosis, especially on biopsy. And if neither of these are available, you should ask. And moreover, since non-sarcomatous lesions are more frequent, they should always be ruled out, as well as benign mesenchymal neoplasm, because they tend to be much more frequent. And of course, the amount of sarcoma you see is important. So if you don't see them on a daily or a weekly basis, it's wise to cooperate with someone that does. And with this, I would like to thank all my colleagues that allow me to do my job in a very good way, and you for your attention. Thank you very much.